Hi everyone. Today we are going to talk about COPD exacerbation, mostly the etiology, the clinical presentation, and the diagnosis. But if we have time, we can also include the treatment, or if the video gets too long, we can put it in another video. So yes, COPD. Exacerbation. So it is a relatively common clinical presentation in COPD patients, especially the elder ones. And it is really important to accurately diagnose it and always remembering the similar presentations that can look like a COPD exacerbation, but in fact it's a really different and maybe more dangerous diagnosis. So we are going to give importance in a differential list. So as the general information, we know that the COPD exacerbation is so the COPD patients they have day-to-day variations. This is normal. So a COPD patient can say that I have dyspnea today. I can't really breathe well. I use my rescue inhaler. However, 2 days later, they can say, "Oh, I feel better. I didn't use my rescue inhaler. I just use my regular scheduled meds." And maybe 3 days later, the same again, like the day one. And this goes on and on for all the time. So that's the day-to-day variation. The patient does not come to the hospital or does not seek any medical support for this. But if the patient comes to you and seeking medical advice or medical help, it is usually not their day-to-day variation. So they will say, so you should exactly ask, is this your day-to-day variation? I mean, did you have this last week, last month? And probably if it is a COPD exacerbation, they will say no. So they will worsen, unlike their um, regular clinical variants. Okay, so I can say not day-to-day variations, and usually in the end we switch the medications. So a COPD exacerbation is not something like, okay, the patient has the exacerbation and now it has passed, the patient feels better again, and now everything will continue like before. No, it's not, because this can be dangerous in COPD patients, and we certainly do not want that to happen again. Therefore, we usually switch their medications to a more potent bronchodilator, or we add some other medications that we're going to talk about, so to prevent this to happen. So for example, if a patient is always experiencing COPD exacerbations for the past year, then we can safely say that it is not being managed in a good way. Therefore, we don't want this to happen. Yeah. So, and we switch the meds in the end. Okay. Sorry for my awful writing. I hope you can write it. Or you can read it. Yeah. So, and in general, there is an acute change in at least one of these three symptoms. First one is the cough frequency, or in cough amplitude. For example, the patient says, I'm coughing much more than much more than before, or they say my cough, like I'm coughing as usual, but it's much more worse. For example, I'm producing always sputum because I cough so hard. The second one is sputum amount or character. This is fairly straightforward, and sputum amount increases or sputum character increases. For example, it is more liquid and it started to be more solid, or the color changes. And the third one is increase of dyspnea, and this is probably the easiest one to think. Okay, so there are some risk factors that make the patient more likely to have a COPD exacerbation. And okay, risk factors. So first factor is older age. I mean, there is no definitive cutoff, but if a patient is older, for example, a patient who is 60 has more risk to have a COPD exacerbation than a patient who is 40 years old. Second one, if the patient has productive cough, which means cough plus sputum production. So if a patient has, for example, chronic bronchitis or a problem that he or she frequently produces sputum in their baseline, this has found to be a risk factor. Third one is the total COPD time. So if a patient says that I have been diagnosed with COPD for only 2 years, probably if they are not very old, an acute exacerbation is not expected if their disease is managed correctly. But if a patient has, for example, 30 years, like living COPD for 30 years, that increases their risk for a history of exacerbation. Sorry, a history of course, exacerbation, but exacerbation with inpatient stay. That is pretty straightforward. If a patient has a history of exacerbation, they are more likely to undergo another one. And there are two possible reasons that comes to my mind. First of all, it may not be managed as well. Or the second one is they have an exacerbation, so their COPD is not in a very early stage. Therefore, it's more likely to undergo another one. The fifth one is a history of antibiotic use. The sixth one is chronic mucus hypersecretion. The seventh one is high eosinophils, and there's a cutoff 0.34. Eighth one is theophylline treatment. And the final one that I want to say to you is the having comorbidities. More than one. For example, diabetes, heart failure, ischemic heart disease. chronic kidney disease, etc. Okay, so these are the most common risk factors that we should account for. So if a patient comes with some symptoms, or if a patient is just a stable COPD patient, but he or she is, for example, 75 years old, has productive cough, diagnosed 40 years ago, exacerbated in the past year 2 times, and used antibiotics for pneumonia or another infection, and has, for example, increased eosinophils, the patient is in a pretty high risk for um, another exacerbation event, and all of those are independent risk factors. So, yeah. And so there are some other factors that additional factors that may increase the risk for undergoing an acute COPD exacerbation. Is that was a study called Eclipse, and this study followed moderate to severe COPD patients. They followed them for 3 years, and they tried to analyze if there are any additional factors, risk factors. So they come to the conclusion that past exacerbations are the most important and the most important cause, or the most important factor that shows us the patient can undergo another exacerbation, past exacerbations. And the second one is they found a couple of additional risk factors. The first one of these additional factors is gastroesophageal reflux disease, which is really logical. I mean, this also is linked with aspiration pneumonia, and pretty much lung infections are really in a strong relationship with reflux. I suggest you read a couple papers. There was a really cool Nature paper, I guess in 2016 or 2015, that reviewed reflux and the lung infections. Sorry. Or the heartburn as a symptom. This also, the COPD patients who have this symptom are also found to be more likely to undergo an exacerbation. Yeah, that was a 2010 study. I suggest you should read it. It was published on New England Journal of Medicine by Hurst and colleagues. So, yeah. So, I want to tell you about the pathogenesis of very shortly. So, these are the risk factors, right, that we mentioned about. So, what leads to the exacerbation itself? What makes the patients undergo these COPD exacerbations? And in 70% of cases, it is a respiratory infection, mostly viral or bacterial, and some rare causes have atypical infections like fungal. And among the bacteria, the most common ones are Haemophilus influenza, Moraxella, strep pneumonia, and Pseudomonas. And this is really important as the cause, and we are going to talk about the treatment. And when we are going to talk about treatment, we will give special importance if we think that it might be Pseudomonas aeruginosa, or it might not be Pseudomonas, then our treatment pretty much changes in a big time. Okay, so what is the last 30% is they said it's pollution. People also say it can be pulmonary embolism, so not a very big like wedge-shaped that lodges in the main arteries, but probably the small, maybe unnoticed embolism events and idiopathic. I don't like putting idiopathic in the reasons or the causes because it's silly, but yeah, that's so we don't know some of the reasons. Okay, and for example, this I took from the 24 paper from the Sethi et al. The Journal of American Thoracic Society. So, okay, after this boring pages, we come to the clinical presentation. Okay, so there's a range. This is a range, okay? So not the exacerbated patients won't fit in one thing. It's an umbrella, and the ranges it goes from like a mild dyspnea or cough to respiratory failure, and some patients even get intubated. So there's an umbrella here. So so to speak, some of the symptoms are increased cough, sputum, dyspnea, fever. It may be like in the patient if there are fever or chills or night sweats. So this is the most main symptoms, and these are the symptoms that we should ask for it, because it also, for example, the patient may have pneumonia and also COPD exacerbation. Maybe the pneumonia precipitated the exacerbation. So we have to ask for an infection. This one is probably for TBC, tuberculosis. Any coronary event. So we mentioned that patients with comorbidities are more especially if it is more than one, are more likely to undergo an exacerbation. So if a patient has chest pain, a sense of pressure in the chest, peripheral edema, or is there an upper respiratory tract infection? We should ask for this, okay? And there are a couple of questions that we should ask for sure. It is really, really important. Ask, okay? So I noticed that many of my colleagues don't really ask patients about really important questions. So for example, if a patient comes to you with chest pain, you shouldn't directly say, oh, okay, how is the chest pain like? Is it like a pressure? Is it like a sting? Is it like a really big and like really painful thing, or not really important? You should definitely, the first question that you should ask is, since when you are having the chest pain? The patient may, if the patient says, okay, I'm having the chest pain for 1 year, again, you shouldn't dismiss it and just go right into the other questions. You should ask, okay, for 1 year, but of course not all the time in this past year. Probably you are having it once a week or twice a week, but what brought you here? What is the difference? And usually, if it is really like an ischemic thing, people will say, yes, it was like 1 year, but since last week, my pain increased. And you'll ask, okay, like today, explain me today what happened. And they will probably say, today I woke up with chest pain. It did not go. I took a nitrate. It is now a bit better, but I'm still having it for probably like 3 4 hours, and this is like a really important thing. So the time period is really important. Okay, so when did it start? So if a COPD patient that you're trying to understand that if he or she is undergoing an exacerbation, they might say, I'm having this for 1 month. So probably this is not an acute event, okay? But if you do not ask this, okay, and just say, okay, are you coughing? I'm coughing like hell. Are you producing sputum? I'm producing green sputum like hell. Do you have fever? Oh, doctor, I have fever too. Do you feel dyspnea? Can you breathe? Can you breathe well? No, I cannot breathe. Do you feel bad? Yes. Malaise, etc., etc. Okay, and you think that this is really acute and like something that we should just take care of immediately. But just ask the patient, how long has it been going? And if he or she says 1 month, ask what brought you today and not last week. And they will say, they can say two things. I have seen each one of them several times, so I cannot say this is more likely to be an answer. So they might say first one that I guess I heard the most probably, but nevertheless it's probably equal. They say I didn't have time before and I was really busy, or like my son was busy, he couldn't took me to the hospital, and now I can come. So this is not an emergency thing, okay? This is not emergency. You can just chill and try to um, produce your diagnosis in a better way. And the second one is, it's a more alarming. They can say, no, I was having it, but like since yesterday evening, I feel so bad. I couldn't take it anymore. I thought it would pass on its own, but now it is much worse. Then this requires immediate medical attention. All right. So ask the patients about the time. It helped me in a great way. This is, I think, the best question in the history taking and in the review of symptoms. I mean, yeah, you can make a big difference with that. And the second, so the first one is time. The second one is how is it bad compared to your baseline symptoms that we mentioned it, like to understand if it's a difference. The third one is, so it is going more specific. So we started with a time. It's a very important and general and basic thing. Then we are going to more specific questions. Of course, there are like tons of questions that we could ask, but those four that I'm going to mention at one more two, that are the questions that we must ask. The third one is, when is the dyspnea start? When does the dyspnea start? So 2 is baseline, 3 is dyspnea. So if it starts when the patient is just sitting in his chair, or the patient has really big dyspnea when he or she is trying to go up to the stairs. That's a really important difference, because if it is when they are resting, that means that can be real severe. And the fourth one is that ask about the sputum. The color, is it purulent or not? Of course, you should ask it in an appropriate way, and the amount, and compare it with the baseline. And the final thing that we must ask, and like we shouldn't forget it at all, the history, the COPD history. Take a really detailed history of his COPD. So when did it start? Any past exacerbations? As we saw in the Eclipse study, the past exacerbations are the most important risk factor. Is the patient using systemic steroids, prednisone? This shows us that it is a really severe COPD, because this is the last step of the treatment algorithm. Did he ever got intubated or assisted ventilation? Like no, with non-invasive probably. So yeah, this is also really important that we should ask. So let's come to the physical exam. Probably the most common thing that we see in the physical exam is wheezing and tachypnea. The patient may have difficulty speaking because they are gasping for breath. They may use accessory respiratory muscles. For example, if they have using other muscles, and related to this one is the paradoxical chest wall movements. I'm not going to get into a really big detail about this paradoxical movement, but just in a very basic way to tell, normally the chest wall and the abdomen are synchronized when the patient is taking a breath. Of course, the abdomen shouldn't help the breathing. However, in COPD patients, if the exacerbation is severe, they most likely help. And they should be synchronized. So they should move at the same time in the same way. However, if there's an asynchrony, so for example, chest wall is going down and abdomen going up, for example, or they're moving in different times, then this is the paradoxical chest wall movement. And this is a really cool thing to write in the clinical sheet, like when you are writing about or when you are telling to your attending or your friend, the patient has paradoxical chest wall movement. Wow, yeah, you're now badass. All right. Some other things. If it is really severe, the patient may come with hypercapnia or hypoxia signs. So this is really important. So for example, you should look if there is any cyanosis, if the patient has normal capillary refill time, do a pulse oximetry. If the patient has mental status change, like a really hypercapnic patient will be in confusion or even stupor. Okay, I guess it's stupor. Or even like if it is really severe, we may see asterixis. But this isn't seen in hypoxia, only seen in hypercapnia. Both of the other ones are also be seen in hypoxia too. Also, we should so this was in general, and what I need everyone to look for is to see if there is any signs for respiratory arrest. So if there's an emergency or not, if we act quickly and immediately or not. This is really, really important. And I think we are not going to have time for treatment, so we are going to build another video for that. All right. So we should look to the signs for respiratory arrest, because if you don't look it, if you don't think about it, the patient, while you are just ordering some blood tests or chest X-ray, you may hear that they are calling the code. So we don't want that. So always look to the signs for respiratory arrest in a not very well looking COPD patient who has come to the hospital or emergency service to seek help, okay, with dyspnea. So first one, is the patient really starting to not really giving an effort for the breathing? So loss of the respiratory effort. The patient may even say, I cannot continue like this, because some of them are really dyspneic in their baselines too. So they're always trying their, like giving a really hard time to their respiratory muscles, and in an exacerbation, it just skyrockets. So they may say, I am, but there are other ways to see this too. For example, if they're losing the respiratory effort, then we will going to see some kind of respiratory acidosis, but you should look to the signs first before the lab work. The second one is cyanosis, and this also shows the loss of respiratory effort too, and this is a really important thing. And sometimes the patients look pale or like blue, okay, but we will not maybe understand that if it is in their baseline too. So always ask the patient relatives, is this the usual color of the patient's face, okay? The third one is hemodynamics instability, for example. So what is the BP? What is the heart rate? Okay, this is really important. For example, the patient comes, immediately obtain, like tell that the nurse or PA that they should obtain the vitals. So for example, if it is 80 to 50 and heart rate, for example, is 130, it's not looking good. I mean, and you should just act immediately. Of course, the patient may say, my blood pressure is always around 80s, then it's not really bad, but you should just monitor the patient continuously. And the fourth one is the mental status change. And this is really important because we should ask not the patient probably this to, and we should ask to the relative. If the patient is not living alone, their relatives or their house members will say, yes, this patient is not behaving like before. This is not his or her usual self. And this is really important because this shows hypercapnia and really, really important because this occurs in last. You can see many COPD patients who are like stable but probably severe, and they come with hypercapnia, and they are usually not mandated. So their mental status are usually normal. They can talk to you. But if a patient is not responsive, seems confused, always ask the patient relatives, because some of those may be like this for a few years or several years. And but if it is recent, we should see this as a red flag, as an alarming symptom. Okay, so we try to do a couple things. We try to see that if there's any symptoms or signs for immediate actions, emergency. This is really important. Then we made our physical exam. Together with this, we took the history, which is really important. Then if we decide that the patient is stable, then we can proceed for the clinical evaluation. But if the patient is not stable, if the patient's vitals are declining, if your physical exam found a really massive pulmonary edema, or if the patient's history is so bad, for example, their heart may they can also undergo myocardial infarction if they have a ischemic heart disease history, because then they're in tachycardia, their heart may not get enough blood to supply because it's working now much faster than before. For example, if the patient says, I have really big chest pain, yes, I had dyspnea, but now, like for 20 minutes, the chest pain is incredible. You do not do the clinical evaluation, like all the steps that we are going to mention. You just obtain an EKG, and you just continue monitoring it. And for example, and after we are sure that the EKG is fine, you should just monitorize the patient. You should ask for if you are in an out of hospital situation or in an outpatient office, then you will consider that to transfer the patient to a facility with an emergency service. Okay, so our clinical evaluation comes later. We have to understand the patient, that the patient is stable. Okay, and another note, if the patient seems very bad, so you think that there might be something going on and you should do something, but maybe you are in a clinic that has no resources, and for example, you want to send the patient to an emergency service, but you don't have an emergency service in your clinic. Do not ever say that, okay, you to your patient or to your patient relative, okay, go to the emergency service in this location. This is the closest one. Take him or her immediately. You don't say this, okay? If you can, if there are like resources, call 911 or your emergency contact, or just use a vehicle for transportation of the patients, that you yourself organize the transportation, okay? But if there are no resources there, and if there is no ambulance, if you're in a really rural area without medical services, then it may be understandable for you to say to the patient relative, okay, just drive so quick and get this patient to the emergency service, okay? And it would be nice if in that situation, it would be nice that you also go with the patient, because if the patient gets worse in the car and in the vehicle, then you can maybe do something. Okay, yeah, so this was a bit off topic, but okay, we are now in a clinical evaluation. And okay, we will do clinical evaluation in a different video. This was the COPD introduction, etiology, and the clinical presentation with some important tips to understand that if the patient requires immediate medical attention or not. I was Dr. Sodol, and thanks for watching. I will create another video for clinical evaluation and the differentials, and another probably video for the treatment aspects, because because both are really important and long. So thanks for listening. Take care.